Okay, good. We have a few more people coming. I'm going to get started if that's all right. So welcome to the last of 3 installments that we're doing to try and prepare our nursing unit for a very successful Gnosis or Relias testing period, which is open now and coming up over the next couple of months. We decided to look as our third topic at vacuum delivery. That's because it's tested, but also because one of the measures that we looked at as a unit in terms of our quality and safety improvement projects this year was on vacuum delivery or operative delivery. And so that's why I chose to review this today. And this presentation is largely based on a practice bulletin from ACOG, which is sort of the authority on obstetrics practice. And this is not really new information. And if you look at the ACOG's practice bulletin, it was written originally in 2000 and reaffirmed in 2019. Very, very little changes in the world of operative vaginal delivery. In terms of the background, a little bit about vacuum delivery, about 1 in 20 or about 5% of vaginal births tend to go towards an operative delivery. And by operative delivery, I mean vacuum as well as forceps. Although forceps are so rarely performed anymore, I'm really talking about vacuum delivery when I talk about operative delivery. Forceps became popular in the 50s, unfortunately due to profound neonatal and maternal lacerations and injury with the use and inappropriate use of forceps, a transition towards vacuum delivery, which really vacuum deliveries kind of peaked in the mid-90s and now are actually on the decline. And there are some calls within literature currently to really train providers in vacuum delivery because we're seeing fewer providers being trained in forceps. What we're seeing now in modern medicine is fewer providers also delivering with vacuum forceps, vacuum deliveries, but there can be some benefits. And so it is an important tool to have in our armamentarium as obstetricians. And the biggest benefit is really going to be avoidance of cesarean delivery in certain scenarios. In addition, vacuums can be used to shorten the second stage, and it can get a baby out faster in a pinch if needed. Indications for vacuum delivery, really there's not very many. It's really just a handful of reasons to use a vacuum. And that includes a prolonged second stage of labor. And I used to have a definition up here in this slide from way back when, about 10 years ago. And now the definition of what's really too long is kind of up in the air. There's no real set, nice, magic number. And so, unlike ACOG, I left this other indication in here, and that's maternal exhaustion. In combination with a long second stage and then mom's fatigue, that's really when that second stage starts to be too long. And if you're using a vacuum when the mom's too tired and she's unable to give you any assistance, it really isn't a good idea. So in this list, I would kind of probably, if it were up to me, combine these ideas together. It's taking a long time. We think she's getting tired. We need the baby out before too late. As long as there is progress in the second stage of labor, it is not considered prolonged, meaning if there is descent, then that is considered acceptable progress. It doesn't have to be fast, okay? And then the second indication would be suspicion of immediate or potential fetal compromise. So again, we don't want to be using a vacuum once the baby's already acidotic. We want to be doing this in advance or in pending acidosis. And that would be as detected through fetal heart rate monitoring or through other signs, like if there was a large abruption and heavy vaginal bleeding at complete, for example. And we can also use a vacuum to electively shorten the second stage of labor for maternal benefit. And this would be in cases of either cardiac disease in the mom, where we want to avoid Valsalva to keep her cardiac output flowing, or in cases of maternal neurologic disease, where we want to decrease intracranial pressure due to Valsalva. And those two indications really are kind of also going by the wayside. What it turns out is with Valsalva, you really change very little the intracranial pressure. And so most neurologic injuries or disease that we used to think we should vacuum for, really probably we don't need to. And same is true with maternal cardiac disease. There's very few indications really where we should just apply the vacuum just because we can. So there are different types of vacuum and forceps deliveries, and we classify these in terms of where we start. So there are sort of 4 types: outlet, low, mid-pelvic, and high. So outlet operative delivery or outlet vacuum delivery refers to the vacuum being applied when the scalp of the fetus is visible at the introitus. This is the majority of what we do, is when we see the scalp. That's without separating the labia. This means that the fetal skull has reached the level of the pelvic floor. In an outlet delivery, the sagittal suture is in the AP diameter, meaning that the baby is either straight OP or straight OA. And the fetal head is at or on the perineum. And that fetal head, the angle of the occiput or that mid-sagittal suture is within 45 degrees to the maternal midline. So this is not a rotational forceps or rotational vacuum. A low vacuum refers to a head that is at +2 station or more towards you, further out, but not yet reached the pelvic floor, meaning we can't see the head just with hands off looking at the mom when she's pushing. Okay, so +2 to sort of +5. And a low forceps, the rotation again is within 45 degrees, or if we are planning to use the vacuum or the forceps to rotate the head, that's called a low rotational forceps. We can't really rotate with the vacuum, so it's a little bit of a misnomer. You can turn the vacuum, especially with some of the rigid cups that I have here, you can help, but it is thought that the more rotation you apply with a vacuum cup, even with soft cups, the more chance you have with laceration. So while it is possible to classify a vacuum this way, this is really more traditionally thought of in terms of forceps, where if the baby was needing to be rotated, we could actually use the forceps to turn the baby. And that was done even more often in mid-pelvic or high forceps, and that's when the baby's head is not high forceps are when the baby's head's not engaged, it's above 0 station, and mid-pelvic forceps are when we're at 0 station to +2. We really don't apply vacuums to mid-pelvic or high deliveries. The contraindications to vacuum delivery are actually very few absolute contraindications. If we knew, and this is sometimes hard to know, but if we knew there was an underlying fetal disorder such as osteogenesis imperfecta, which is brittle bone disease, where the vacuum may cause a fracture to the bones of the baby, we would not apply the vacuum. That would be an absolute contraindication. Or if we knew that the fetus had hemophilia, which most of the time we're not going to know. So these become sort of relative contraindications, but in a mom that we knew had a prior affected child with hemophilia, we would not apply a vacuum to a male fetus. Remember, only males are affected by hemophilia. Or failure to fulfill the requirements of an operative vaginal delivery, and I'll go over that in a minute, but if you can't, we have a checklist of things we need to do to make sure it's safe to apply a vacuum. If we can't meet that checklist, then it's contraindicated. And really, these things are going to be the same things that are required for vaginal birth, right? So we can't have a previa, can't get a vacuum through that. And then if the provider does not have privileges for emergency cesarean delivery in the event the operative delivery is unsuccessful, and this is really kind of a key point, this is not to be provided by mid-level providers who don't perform emergency C-sections, because you need to have a backup plan. Any good vacuum has an out. So, and the most important things in terms of safety in vacuum delivery is that you need to be willing to abandon it, and you need to have a path to a safe delivery in the back of your mind and always available, or you shouldn't be performing the procedure. And then failure to get informed consent is can be a contraindication.
Do you guys know how to find your provider privileges? Do you know where that's at? Okay, so there's a sheet up in the break room, and it tells you how to log in and where to find the provider's privileges. Dr. Roloff has all the privileges.
Okay, so Andrea, just so this gets into the talk, just mentioned that provider privileges are something that any nurse can look up, any provider can look up. We do maintain privileges. We know what we're privileged to do. Any provider here that you're going to work with knows what they have privileges to do. That's part of our responsibility as physicians. Considerations in vacuum delivery, meaning not contraindications, but things that we should maybe be wary of. And that's providing vacuum birth when there's maybe some cephalopelvic disproportion, which is a really hard thing to quantify, but if the baby's big, that's going to be a warning sign. In a 4,500 gram baby, we need to use caution with vaginal or with vacuum delivery. It's not a contraindication. There's many women who can push out a 10-pound baby and maybe need to have a vacuum assistance, but it is a consideration because we do see in larger babies with vacuum birth a higher chance of shoulder dystocia. And that's something to keep in your mind as a nurse. If we're vacuuming a larger baby, you need to not just remember that path for safe delivery in the operating room like C-section, but also what am I going to do if there's a shoulder dystocia and what do I need to do to get ready for that? If there's uncertainty about fetal position, really in training providers, we train them if you don't know the position of the baby, if you can't find the occiput and you can't find the fontanelles, you really shouldn't be applying the vacuum, because if you apply vacuum over a soft fontanelle, you can cause an increased chance of intracranial hemorrhage. But sometimes we're not 100% certain, right? We have a reasonable, educated physical exam and we think we're doing the right thing. So that's reasonable, right? So we should be able to tell the fetal position, but we may not be 100% certain, but we may be certain enough that we think it's safe to proceed. Adequate anesthesia should be a consideration. Certainly there's intense times when the fetal well-being matters and mom's not anesthetized for vacuum delivery, but it does hurt, and if we do have time, that should be something that we consider, maybe performing a pudendal block or at least lidocaine insertion into the perineum for the vacuum birth. And then we do need to be careful. We don't do scalp sampling anymore, but if no, but just in case it comes back, because you never know. But if you had multiple injuries into the soft tissue of the fetal head, you would probably want to be cautious with your vacuum. And then we really don't know the lower gestational age limit at which it's safe to apply a vacuum, but under 34 weeks, we should be very cautious. We do know that at lower gestational ages, there is an increasing chance of intracranial hemorrhage with vacuum. But again, that's a risk-benefit thing. If we're 34 weeks or 33 weeks, the head's right there. We have somebody else in the operating room. We have fetal distress, and this is our only option. This might be the best option. So it's a consideration and not an absolute no. There are different types of vacuum devices out here, and if you guys want to play around with these, if you've never played around with either of these cups, you should. You should be able to put it on your palm and create the amount of suction that we use, and so kind of get a feel for what that feels like. You should also understand the differences in the two devices that we have. We have both the Kiwi, this is, I think, the Pro Cup. There's different types of Kiwis, but this is actually a rigid plastic cup, whereas the Mighty Vac we have is a softer cup. And which one you use, you can feel on this one. The Mighty Vac, you can squeeze it. It's a little softer. So the benefit of the softer cups are that we see fewer lacerations, but we should have more pop-offs because they're softer. And so this is, which one you want is really just whoever's doing the vacuum and using the instrument, whichever one they call for, that's the one that we should be using. It's really just our preference. There has not been any of these types of vacuum devices that have been shown to be superior or otherwise better than the other. One of the nice things about the newer vacuum devices, when I started my training, we didn't have handheld devices. These all hooked up. We had the cup, we were given the cup, we put it on the baby's head, and then we had this long thing that went to the nurse, and the nurse had to pump it up. And then we were constantly yelling at the nurse to keep it in the green, keep it in the green. And of course, we lose seal sometimes, and that just becomes very dramatic. So these handheld devices actually have helped us quite a bit in maintaining our independence and preventing us from yelling at the nurse about pump now. How is a vacuum delivery done? So here's a picture, cutaway view of a mom with a fetus. This is at +1 station. That would be a little high for, that's considered a mid-forcep or a mid-pelvis vacuum. We don't advise mid-pelvis vacuum delivery. We really should be at +2 station before we are applying the vacuum device. And it's just applied to the baby's head, and I'll go over exactly where, and then we simply pump up the pressure so it suctions on, and then we apply gentle downward traction along the path of the birth canal. The prerequisites are listed here, and I'm going to read them because they're super important. The cervix must be fully dilated and retracted. You have to have membranes ruptured. You can't put this on the membrane. Common sense is a superpower. The fetal head must be engaged, and I would argue should be at +2 station or more. The position of the fetal head has been determined. There is an estimated fetal weight, and that doesn't have to be by ultrasound. Leopold's estimated fetal weight is fine. There needs to be some sort of educated assessment that the baby can fit through this maternal pelvis. Pelvis thought to be adequate for vaginal delivery. Adequate anesthesia. The maternal bladder should be emptied. Patient has agreed to the vacuum after being informed of the risks and benefits. And then all providers who perform vacuums must be, and this is, I think, really a key point, I'm going to say it over and over, willing to abandon the trial of operative vaginal delivery, and backup plan is in place in case of failure to deliver. And I'm going to say that over and over because I think one of the key things that nurses can help with, because we're doing all of this now, it's in our hands, right? One of the things that we really need help with is clearing the path to the OR if this vacuum doesn't work. And it's very hard for us as the physician scrubbing in to do a vacuum delivery. We're going through this checklist in our head, right? We know our backup plan is a C-section. We're talking about that with the patient. But making those phone calls, is anesthesia on standby? Do I have a nurse to help me get this patient to the OR? Do I have a scrub tech? Are they up on the floor? Are they doing something else? Those phone calls, those are actually really important. Just having everybody pause what they're doing and having your OR staff just hang out, be ready till baby's out. That's really key, and that's where I think nurses can really help the providers as they scrub in. In terms of application and technique of the vacuum delivery, the vacuum is placed symmetrically, hopefully in the middle, about the sagittal suture at the median flexion point. And that is really right at the top of the head, that median flexion point. It's 2 centimeters anterior to the posterior fontanelle or 6 centimeters posterior to the anterior fontanelle. So it's on the vertex, really that point here on top of the head. The reason that's super important, if you put the vacuum sort of more anteriorly, let's say not on the anterior fontanelle, and you pull, you get a little extension. If you're further back here and you pull, you get a little flexion. You need flexion to help the baby's smallest part of the baby's head fit through. If you extend, you actually get a wider head circumference coming through the pelvis. And so we often get stuck. So that's one of the key points when we're teaching in C-section how to extract a fetus to our interns. And they'll put their hand in, and I'm constantly saying, get the vertex. And they'll forget to flex the head, and they'll extend the head, and now you're pushing and you can't get that head out because you're getting a wider part of that baby's head through the hysterotomy. So same thing with vacuum, you really need it on the cone head part. We apply up to 0.8 kilograms per centimeter squared of pressure, or 500 to 600 millimeters of mercury, and these devices have made this really easy. You don't even need to remember those numbers. We have a green and a red. What this means is we apply the pressure and suck a portion of the scalp into the cup to the level of green and avoiding red. We do know that as we pull, once there's suction onto the fetal head, that's going to increase the amount of pressure in that suction cup, right? Just the force, extra force. So we don't want to be sitting right at the green to red when we're not pulling. We want to keep our eye on that pressure gauge and make sure that we stay in a safe region. And the Mighty Vac and the Kiwi both have green and red, so made it pretty easy there. Again, empty bladder. And then we'll apply traction force, and this is super important in concert with a contraction and in concert with maternal effort. You will get fetal injuries if mom's not pushing. It's not quite enough force through us pulling in a suction cup. You really need explosive effort of the mother in addition to your pulling efforts. Once the vacuum is applied to the fetal head, what you'll see is we'll usually sweep our fingers around. That's just to ensure there's no maternal tissue stuck underneath the cup. And then the dominant hand should apply downward pressure. And then our non-dominant hand is usually holding, hopefully, that cup onto the fetal head. That's a little tricky to do. We do the best we can. That's to prevent loss of seal or pop-off. In terms of whether we're going to apply traction between pulls or leave the pressure gauge up or down in between pulls when mom's pushing, there is no data showing any difference in outcome, so that's really just a provider preference. Some people you'll see will release the suction cup in between. I think most of us tend not to because we find it's harder to maintain a seal if you're constantly going up and down, and we need that seal, right? That's how we keep this on the baby's head. We're trying to prevent pop-offs and trauma to the baby. So most of us probably leave these just in the green level in between pulls. We would ideally be successful with our vacuum birth within 3 pulls. We know that over 3 pulls is associated with a higher chance of neonatal trauma. Again, this does not mean that we can't pull more than 3 times. It doesn't mean stop what you're doing. It still may be the safest course of action, but it does mean that we know we're getting into a higher risk situation. The longer the vacuum's on, the higher the risk. The more we pull, the higher the risk. The more the pop-offs, the higher the risk. And I'll talk a little bit in a moment about maternal and neonatal complications. The manufacturers, in their infinite wisdom, and I say that with sarcasm, have advised a maximum of 2 or 3 pop-offs. And I can tell you from being in a case where there was not time to get the fetus out and having 3 pop-offs, there are times when you may exceed that, and that may be your safest course of action. We know that increases risk of neonatal injury. We get that, but we also need to try for the best optimal health for the neonate. So there are scenarios, right? There's always scenarios. Just like I said, ideally you don't use a vacuum under 34 weeks, but there are scenarios where maybe that is your safest course of action. So ideally we don't have more than 2 or 3 pop-offs. And again, we train our providers, and I hope all good obstetricians are willing to abandon a vacuum if it's not working well. But again, there are scenarios where maybe you're going to violate some of those manufacturer recommendations. We pull in steady traction in a straight line, and the birth canal, if you look at normal physiology, the path is actually initially the fetal head comes kind of down, and then as we crown, the baby actually we're flexed, and then we come through extension. So you'll see when we're applying the vacuum, we pull initially down, and then it's kind of a J shape, and we actually encourage that extension through crowning. Again, we are always willing to give up if we need to. Reasons for failed vacuum extraction really include poor patient selection, errors in application or technique, especially if we have poor assessment of fetal position, and then overcommitted to vaginal delivery. So if we just need that baby out vaginally, that's when we kind of get into trouble with ourselves, right? So as providers, we need to be willing to disengage when it's not working. Maternal complications really have to do mostly with just maternal laceration from the delivery. That can lead to perineal pain and postpartum pain. 3rd or 4th degree lacerations occur more often with vacuum birth than they do in spontaneous vaginal birth. And there are even higher chances if the baby's in the OP position. Moms can develop hematomas resulting in blood loss, anemia. In addition, there can be local tissue trauma leading to urinary retention if that urethra gets swollen. And urinary and fecal incontinence and fistula formation are very rare long-term sequelae of vacuum delivery. Fortunately, they don't happen very often. There is some controversy over whether to do an episiotomy routinely with vacuum delivery. There are some studies that show benefit. ACOG's position on this is selective use of episiotomy probably is helpful. Episiotomies can, especially if you do a mediolateral episiotomy, can prevent 3rd and 4th degree lacerations by directing the tear off laterally instead of down into the sphincter. So again, I don't think they should be done routinely. If mom's a G5P4, she's had a previous 10-pound baby, we're vacuuming a 7-pound baby for fetal indication and that vagina is just gaping wide open, probably we don't need to do an episiotomy. So to say you should do it routinely is not true. But in primes, probably it should be done pretty judiciously and often to try and prevent actual anal sphincter injury. Neonatal complications also are mostly related to the vacuum causing laceration to the head. And the big bad is a syphilohematoma, which is where you have bleeding into the skin. A subgaleal hematoma, which is bleeding underneath the muscle of the head, and then intracranial hemorrhage, which is actually bleeding into the brain. It is really, really difficult to determine in studies of vacuum delivery if these complications occurred before the vacuum or after, especially because intracranial hemorrhage we're going to vacuum for acidosis because the fetal heart rate looks bad. That increases our chance of intracranial hemorrhage. So was it the vacuum? Was it the condition of the baby? How much is due to the vacuum and how much is due to whatever it was that prompted us to do the vacuum in the first place? So it's really difficult to quantify, but intracranial hemorrhage does have the most profound long-term sequelae for the newborn. Cephalhematomas and subgaleal hematomas are not good, but they ultimately will heal. Intracranial hemorrhages, we think, occur in about 1 in 650 to 1 in 850 vacuum deliveries, so very rare complication. Facial nerve palsies and retinal hemorrhage, as well as hyperbilirubinemia, have been reported as neonatal complications of vacuum birth, but these are very, very controversial as well. And ultimately, vacuum delivery doesn't affect long-term development. So even in the kiddos that develop an intracranial hemorrhage, really, they tend to be small and tend to do very well. Controversies in vacuum delivery and issues. So sequential attempts at instrumenting vaginal delivery actually increase the rate of injury. So you're going to see your most profound complications when we're struggling with a vacuum one type, calling for the next vacuum type. That may be a reasonable thing, that may be the safest course of action, but we know in the back of our minds, the second we call for a second instrument, we increase the chance of injury. If we call for forceps following a vacuum for failed vacuum, now we get into even higher rates of injury. Doesn't mean that you shouldn't, you guys. I know I see it on your face. Don't do it. Again, there may be reasons to do that. It may be worth the risk of an injury because whatever else with the situation, you can't get that. The baby's head is 0 station. You can't, you're +5 station. You don't think you can get that head back up to do a safe C-section. Your OR's full. Your OR humidifier is not working. You can't do a safe C-section. So it increases the chance of injury, but not to 100%, and it still could be something that we use at times when used appropriately. And I know you will see very few forceps in this day and age, and I won't do them unless I don't have another choice. And I was trained in forceps, but I don't feel confident teaching them, so I think in the next 10, 15 years, we probably won't even know where to find them. Yeah. The routine use of antibiotics at the time of operative delivery, there is no evidence that says that we should give antibiotics. Some providers may. There's no evidence against either. The use of episiotomy, like I just touched on, we do know that episiotomy increases the rates of perineal rectal injury, infection, and need for anesthesia as well as hemorrhage, so shouldn't be used routinely, but may be used frequently with vacuum delivery. And then the use of a vacuum at the time of C-section has really been understudied, and it may be a useful tool, so you will see us call for that when we're having a hard time getting the vertex out, especially if there's fetal tone that's causing extension, so we can't get that narrow part of the baby's head through the hysterotomy. In conclusion, I hope you learned a little bit about vacuum delivery here. The nurse's role, I think, like I said, you guys need to be watching us, helping us with documentation, because obviously we're not going to be able to document how long we've got the vacuum on, how many pop-offs. Most of that we can remember, but certainly length of time is a very useful thing for you guys to be watching with us. The number of pushes, number of pulls, maternal effort, the fact that she's pushing as well. Documenting our consent process, because we can't do that because our hands are tied. And then most importantly, helping us clear a path to the OR in case the vacuum fails. And I think one of the biggest thing there is lines. Getting your lines all organized. The second you see us calling for a vacuum, that should be the first thing on your mind is, are my lines free? Can I unplug? Can I get to the OR in a matter of seconds? And I've seen us do it. We're really good at getting to the OR fast when we need to. But that's kind of what should be going through your head. And then making sure you have enough nursing support and backup in the room. If you know there's another C-section going on, making sure that your OR staff calls up a backup crew just temporarily, or at least starts that process in the event the vacuum doesn't go well. And that may mean charge nurse probably knows a little bit more about that. The charge nurse probably should be directing, converting and calling for extra help in case the vacuum doesn't go well. If the vacuum goes well, it's done in 2 minutes, so it's no skin off anybody's back to spend the 2 minutes to come in, all hands on deck until baby's safe and mom's safe. Any questions?
Listening.
Oh, and
Make
listening.
sure you're listening.
Actually, this is another really good point, because one of the things that I see in vacuum birth, actually in any complicated delivery, is a lot of noise. And I frequently have to just yell, shut up. And I mean, I don't sound nice when I'm doing that, but I can't get anybody's attention otherwise. And actually, the attending and resident doctor performing the delivery should be the loudest people. And if you're louder than them, we have a problem. And screaming at the mom to push is not an effective tool.
Thank you.
So really what we should be doing is listening to the doctor's direction. And I've seen this many times. When I can get everybody to be quiet and I can have the mom focus on my voice, I usually can ground her and get her to do what I need her to do. And as the one performing the delivery, I need her to push when I'm pulling. And so that should be under the direction of the delivering provider. Okay, yeah. And being quiet, so that if there is a shoulder dystocia, we can help. And that's another time I've seen the noise level get too crazy, that I have a very difficult time giving instructions to the nurse in terms of what I need you to do. But that quiet, can you now apply suprapubic pressure? That gives us a coordinated effort. We're going to be more successful more often. So thank you. That's an excellent point. Yeah. The mom can scream, by the way. Yeah. Closed glottis pushing doesn't help. But other than the mom screaming her head off, the doctor should be the second loudest person in the room. Any other questions or comments? Question? No?
No, I was gonna ask Julia, because the point you made about forceps being used, it's funny because when we admit and we are in the education part of it, and I go through every point there, and forceps are up, and I'm like, I don't know why, because I've never seen it used. But it's in here, I have to go over it with you, you know, in case we use forceps. I'm like, yeah.
So the comment here is forceps are still in our admit packages, and they need to be.
Yeah.
So let me give you one scenario, one case that where forceps were used. Was in a patient who is complete at +2 station with full cardiopulmonary arrest from a pulmonary embolism. She can't push. You need forceps. So exceedingly rare, but when needed, they are your only out.
Okay.
Yeah.
So also make sure you know where your equipment is. Make sure you know where the vacuums are. I think only one vacuum is in the cart.
And Mighty Vac is in
the other one you need to know is in the main supply room.
It's about 50-50 on the docks here in terms of who wants the Kiwi and who wants the Mighty Vac. And I know I've actually pushed for both to be in every cart, but I don't know if we have enough. I think we just don't have enough. So it doesn't seem to be an issue. So I think the Kiwis are in the carts, the Mighty Vac's in the supply room.
So make sure you know where your supplies are.
Usually the residents who prefer the Mighty Vac, they'll tell you ahead, as soon as they think they're gonna need it.
And the comment is that the residents who prefer Mighty Vac will call early for the Mighty Vac.
Yeah.
Oh, this is another really good point in a teaching hospital as well, is that residents cannot perform vacuum deliveries without an attending.
In the room.
Okay, because they cannot, remember, they do not have emergency C-section privileges. The attending does, the residents don't. So please, with an exception of, there isn't anybody around, please don't let the baby die because it's a resident who's a senior resident and knows how to do that. But they should have their attending in the room, or at least an okay, go ahead. But ideally you need both resident and attending. PAs should not be performing vacuum deliveries.
I get one with Dr. Gomez. I know he's not here anymore. And I know he doesn't have C-section emergency.
Yes, he does.
Oh, he does? Oh.
The comment was you did a vacuum with Dr. Gomez, and he didn't have emergency C-section privileges, but he does.
Okay.
Yeah.
Okay.
And our family doctors all have emergency C-section privileges.
Okay. He just doesn't like doing C-section. That's what it was.
All right. Well, thank you guys for your attention, for listening. Good luck on your Gnosis Relias test. You guys are all going to ace it. Be confident. Go out into the world, do great things, deliver healthy babies to healthy moms.
Thank you.